going to try to keep us roughly on schedule. And we are now going to move from the last panel, which was really about building data ecosystems, to thinking about urban informatics. And we have something which we built as a fireside chat, which is going to be chaired by Peter Marx. And Peter, I'll tell you two quick things about him. He's by title Vice President of Advanced Projects at GE Digital. And if you look at his bio in the book, which I would encourage you to do, he really has lived a life in the digital world. Before here, he was Chief Technology Officer, City of Los Angeles. And LA has actually been recognized as #1 or #2 digital city. I actually want to know which one was the other one that beat you out for #1. You have to tell us that. But as you'll see, he's actually had an extensive career in working in digital in a number of corporations. So I think he's actually the perfect person to join us today and chair the fireside chat. Peter.
I don't know. Oh, is my mic working? It is. Oh, good. Okay. So I will sit over here, I guess. We're going to flip our plans. So my name is Peter Marx. I come from the other side. When I checked into the hotel yesterday, they said, how long are you here? And I said, well, through today. And they said, oh, good, the weather will get better. So the way that, the way that I look at informatics and data and healthy cities is colored through a couple different lenses. My background is that I've been working in technology for a long time. I wrote one of the very earliest teleradiology systems, PACS system at UCLA. I was on the team who did this using some really early computers, the first color Macintosh and things like that. And when I was finished with that, I actually got roped into going and working for Apple Computer, which was fun. And then wandered off into video games and a lot of different things that didn't really have any relationship to health. In fact, I think it's sort of the opposite of health. You work all night producing products that then get people to play your games all night. That's a whole different thing, sitting in front of a computer. So it's probably not the most healthy occupation on the planet. But it does bring up a lot of interesting stuff, which we'll get into, which is around behavior and sources of data and analytics and so on. And then I was the CTO for a couple of the big media companies, for Universal Studios and Viacom, and then ran R&D at Qualcomm, a chip company. How many people here have a smartphone? Okay, that's about right. Anybody here? I'm not going to out the person who doesn't have a smartphone, but Qualcomm is very much the company, one of the seminal companies that produces the chips and the underlying technologies that are in everybody's mobile device, and increasingly in your wearables and things like that. And strangely enough, I think we would all agree that they have an impact upon health and the availability of data. And then Jascha and I both have a background in city government. I worked as a CTO for Los Angeles, and we'll get into that. And now inside of General Electric, we're working on data and analytics and background systems that really have a worldwide application, and we'll start that. But it's sort of like the old joke, if you will, somebody sits there and talks about themselves, and then says, okay, now let's change the subject. So what do you think of me? But we don't have to do that. But I would like to introduce two practitioners, two very senior, high-level practitioners who are working in exactly the area of healthy cities and informatics. And with that, let me introduce my colleague, Jascha Franklin-Hodge, who is very much here in the city of Boston. And then Sanji Fernando, who works for United Healthcare, who's very much in the focus, if you will, in the delivery of health and insurance and corporate wellness and a number of other things. And between the three of us, we were going to have a conversation that really touches upon, if you will, the outcomes that we're looking for, the challenges that we see, and then the applications of these emerging technologies and the opportunities, if you will, that we see coming forward. Jascha, would you like to maybe frame both a little bit of your background, but also talk about, the framework that you have with the City of Boston?
Yeah, absolutely. Thank you, Peter, and thank you for having me here. So I'm Jascha Franklin-Hodge. I'm the Chief Information Officer for the City of Boston. So I run the city's IT organization, which is in some ways a very traditional IT organization that does networks and computers and software systems. But we also do some work that is outside what is usually an IT scope. So we have a team called the Citywide Analytics Team that works with departments across the city to help them use data to improve quality of life and to improve the effectiveness of their operations. So we source interesting challenges and places where departments can benefit from having access to new data sources, access to analytical techniques that they may not have in-house, and access to people who can work with them to translate their deep expertise in their functional area into data problems and opportunities to use data to make an impact. A couple of examples that tie, briefly to the health space. So I think you heard from somebody from the City of Chicago, or previously with the City of Chicago earlier today. We, like Chicago and a few other cities, are using data to improve the efficacy of our food safety inspections in restaurants. We're analyzing multiple data sources using predictive modeling techniques that essentially allow us to prioritize restaurant inspections based on risk scoring that incorporates past history, that incorporates other information we have about the physical building and the infrastructure in which the restaurant is located, even looking at social media data, in our case Yelp reviews, and keywords that appear in those reviews that might be an indicator that there's a food safety issue. If somebody talks about getting sick in a Yelp review, that's something we want to pick up on. Though differentiating that from, this place has sick margaritas is sometimes a little tricky. So, the new... So the nuance in data science. We are doing interesting projects around new data sources that can be helpful with traffic and traffic safety. We have a pilot project going on right now at the intersection of Mass Ave and Beacon Street here in Boston, which some of you may know is a very crash-prone intersection and has fortunately seen some recent fatalities. And so we've, working with Verizon, instrumented the intersection with a variety of different sensors, and we're using that to capture data about what kinds of interactions happen on the roadway that could, if we could change, could potentially have a positive impact on safety. So for example, how often does a car cut off a pedestrian in the crosswalk? How frequently does a cyclist run through a red light? How often is there a truck parked in the bike lane that forces the cyclist to swerve out of the lane? So we're working to identify some of the early precursor data that gives us a sense of where there is and isn't a safety issue, and then to test intervention strategies with real-time access to data as to what the impact of those interventions actually are. And then we're working with on some projects that are really not necessarily sophisticated from an analysis perspective, but have hopefully a big impact on care and service delivery. We did a citywide project around performance called City Score that tried to establish performance targets across a huge variety of metrics, from how long it takes us to fill a pothole to how long it takes an ambulance to arrive on scene. And in that work, one of the things we identified was that our ambulance response times were slipping below the thresholds that we had set as targets. And we learned, so we dug deeper into that, and two things came out of that. One is that we simply had not kept the capacity of our EMS system to match the population growth in the city, and so made some investments to bring more ambulances and more EMTs into the city operations. The other thing we learned is that a lot of our EMS units were tied up on responses to calls that didn't actually require a unit capable of transport. I think you saw from Monica earlier today some stats about where we have challenges with opioid usage, and there's some concentrated pockets where we see a high volume of what are termed like unknown investigation calls. And more often than not, these calls don't result in a transport, and often there is a medical intervention required, but also a service referral or another type of support that is needed. So in the budget that Mayor Walsh announced today, based on this analysis of these 911 calls, he's funded the creation of a community response teams that will be foot or bicycle-based EMTs that can go into these places and respond to the types of calls that typically don't require a transport. That, as been noted, hopefully improves outcomes for the patients and the people that we're interacting with by giving a more specialized team that can provide access to services, and also frees up ambulance units and hopefully improves response times for the rest of the city. So those are just a handful of examples of the kind of thing that we're doing, but really looking across the city. I think our biggest strength is that we are not specialists. I'm not a public health expert. I know very little about public health, but we can bring a team of people with really specialized skills and partner very closely with the people who are the domain experts and help them increase the impact of their work and their commitment. So that's really the goal that we have.
So I guess I look at you as being a horizontal layer. You know, you're the chief information officer, right? And your job, to a certain degree, is to be able to identify the sources of information and then deliver them to the people who are the subject domain experts, right?
Yeah.
And Sanji, you have a very similar role, adding in analytics for a very large healthcare provider, right? For United Healthcare. And
that's correct. You know, my name is Sanji, Fernando. I work for Optum Labs, which is a research and innovation center that is part of United Health Group. Optum is a brand that hopefully many of you are starting to learn and know. Most of the U.S. is not too familiar with us, but we're a very significant portion of the U.S. healthcare system today. And Optum Labs is a place where we're trying to improve the U.S. healthcare system for everyone, not just for United Healthcare and our members, but everyone, providers, payers, governments. And we started at the heart of the labs is a de-identified copy of the data we generate across the healthcare system every day. We've safely de-identified the data by taking out a lot of the direct information that might identify individuals, but we've also statistically de-identified the data, so we're very certain that there's very low re-identification risk. And so that's where we start. And at the labs, we're doing all sorts of interesting things around collaborating with universities to publish papers, to explore new ways to translate insights that we're generating from this data into care with our partners like the Mayo Clinic. But I really love my job. My job is I run the Center for Applied Data Science, and while that sounds pretty interesting, what I do is I spend a lot of time reading the Google research blog and the Facebook engineering page. And the things they're doing around translating text from different languages or recognizing images are fascinating breakthroughs that I'm now taking and trying to apply back into the healthcare setting. So what does that really mean? Today, many of you, if you're insured by a private insurer, rely on a network of physicians who deliver that care. And for the last 20, 30 years, we've thought of those as simply relationships between a payer and a provider. But what we found in some academic work is that providers self-organize. They know who to trust and who to work with. And when some academics did some small-scale studies, they found that those providers who collaborate more closely together really do achieve better outcomes for their patients. And so using a lot of the advances that companies like Twitter and Facebook have made in recommending tweets or friends to you, it's a space called graph analytics, we're now understanding our network of providers and how they're naturally collaborating together. Right. And it's fascinating because it's uncovered these hidden networks in our large provider network that we didn't organize, we didn't architect, we didn't orchestrate, but we want to encourage because they're achieving great outcomes for our members, and it was all hidden to us without the advances made in other industries to illuminate that. The same thing's happening with, I referred to a little bit about the image recognition. There's a whole class of artificial intelligence called deep learning that the results we're seeing in other industries are fascinating for us inside of healthcare. Because for the first time, we can look at really complex multifactorial problems where in the past, even with conventional machine learning, we had very limited improvements in lift and result. But we're finding that because we have all this data and it's coming in every day, millions of claims, billions of dollars of claims coming in every day, with deep learning neural networks, they actually get better with more data and continue to get better. And so when you think about complex decisions like, for our members, how to pick the very best fit provider for them, given their conditions, given their access, given their socioeconomic status, maybe their plan. It's a very complicated question. Can we help give them tools based on these networks that'll make the best decision for them? So that's really exciting for us.
I mean, having worked a lot on computer vision and character recognition and everything else, I will say that at Qualcomm, we decided very specifically that we were not going to try to interpret doctors' handwriting.
That is very smart.
It's a scale beyond what we're able to.
Yeah, I think Stanford did some great work.
Yeah.
They classified skin lesions,
Yep.
and I was thinking like, well, that's really smart. You definitely don't want to look at handwritten notes in an EMR.
No, definitely not. But so both of you are looking, at this with a goal towards what the title of this conference is, which is healthy cities. We'll extend it to healthy communities and everything else. And you're both making use of data that really has never been available before, right? Traffic counts and traffic studies used to require a human being walking out to the sidewalk and standing there going click, click, pedestrian, car, that sort of thing, right? And traffic collision data came from somebody reporting it to the police and then going through a whole variety of different governmental agencies and then off to the races, if you will. Where do you see the state of the art going in, let's say, 5 years with data sources? Or is the entire city going to be instrumented? And obviously we're going to get into privacy and security issues.
Absolutely.
But is every medical record going to be available to everybody? I mean, where does the data collection go over the next coming years?
I mean, I think there's a lot of directions that are being explored right now, and for us, when we think about how we approach using a new data source, putting in sensors, we really want to start with a hypothesis of how that can lead to value.
Yeah.
I think we've come to kind of fetishize big data in this way that there's a sense that more data is obviously better. And I often have conversations with people who are selling data collection systems that are sort of like, oh, we're going to build, you'll buy this thing and then you'll get all the data, and there's this like ... pause, and they're like,
Right.
and you'll figure out all these valuable ways to use it. And we're like, maybe, but let's actually talk about what those can be in design systems that are rooted in outcome goals that we want to have. So, I mean, that having been said, I think there's a lot of promising technology that's on the horizon. I mean, simply the fact that almost everyone in this room and almost everyone in the city carries with them a powerful connected computer with a whole kit of sensors attached to it with them at all times. That alone has some really interesting value potential. Again, on the traffic safety front, we did a project that it was a competition called Boston's Safest Driver, which you can imagine was got a lot of people, engendered a lot of laughs. But what we did is we had people run an app on their phone that used the GPS and the accelerometer data from the phone to identify the risky behavior that they may exhibit. So were they accelerating quickly at stoplights or braking hard? Were they speeding? How often did they pick up and look at their phone while they were driving a car? And this is using literally no additional sensors, no additional tools, just something that people carry with them every day. And the primary goal of this project was behavior change. It was to reflect back to people what they were doing that was safe and what was unsafe and get them to make better decisions. But we also captured this incredible wealth of data about where there are hotspots of unsafe behavior, which may lead us to make design changes to the physical infrastructure or do other types of broader scale education interventions around certain types of behavior. So I think those, that's a starting point. I mean, Apple Watch and Research Kit is this, really interesting tool to start to get actual, truly health data accessible in a research context and in a research environment. The advances of video analytics are really enticing for us as we start to think about, with cameras that are already in place or cameras that may be added, what can we learn from that? So I think for us, we really want to stay rooted in a set of goals and priorities around around equity, around safety, around what it means to have a healthy community, identifying the places where our communities are not as healthy as we want them to be, and then coming up with projects where we can test where and how these new technologies and new data sources can actually deliver real outcomes on the things that matter to people.
I think I would echo everything you said. In big data, I feel like there is this field of dreams strategy. If you build it, they will come. If you bring all this data together, people will convene. And Optum Labs has done that. And I could tell you from our experience, if I had to do it again, I wouldn't do it the same way. What we're learning and finding in our own large enterprise, which might be a little akin to a small, densely urban environment, is the data is changing and being created so quickly, it's hard to keep up. By the time you organize and assemble the data, you're always going to be looking retrospectively. And so if I had to rethink our approach, and if I looked out 5 years on what I think about an urban sort of data framework, it would be almost a conversation leveraging microservices and APIs, where if I have my use case, I know what I want to accomplish, I have a lingua franca where I can engage all the data sources and assemble what I need.
So what you're saying is that instead of bringing all the data to one data lake or data ocean, if you will, that instead the data stays where it is, right, in these departments and agencies and companies and individuals, and it's interoperable, right? You can get the data.
That's exactly right. I think from what I've seen and observed, that's the only way you can not simply stay current, but not also incur this massive hidden cost to organize, curate, and manage this beautiful data lake. Conceptually, if you have your management consultants come in and tell you need a big data lake, what I don't think anyone really estimates very well is how much does it cost to maintain that lake.
Well, the data starts to decay the second you get it.
Exactly.
There's also huge privacy and cybersecurity risks that come with that model.
Yeah, well, and that actually is exactly where I wanted to go, which is there's a tension where probably everybody in the audience is saying, okay, wait, what about my data, right? How do I control my data? And if I work for a company, how does my company control data? Without meaning any offense, do I have to give all of my data to various governments and to various, insurance companies and hospitals and agencies in order to be healthy, right? That's sort of what we're getting to. And I would like to explore, in fact, actually, how do we maintain some level of personal privacy and personal security around our data within this framework, yet still get the benefits of public health and all that. And
I mean, so I'd start by saying, we are. We think about the existing privacy frameworks, HIPAA and things like that. I'm a relatively sophisticated consumer, and yet I have literally no idea who has my health data and what they can use, what they can do with it. I have signed, every time I pick up a prescription, I sign a thing. Every time I check in at the doctor's office, I sign a thing. I don't really know what that means. And so I think it's important to start this conversation from the place to say of honesty and saying that, what HIPAA has done is provided a lot of great legal cover for entities involved in the healthcare system. What it has not done is empowered consumers to actually understand what data exists, who has it, and what it's going to get used for. So I think that has to be a frame that we start to try to develop. And somebody on the previous panel alluded to this. It's like, how do you engage people in a conversation that is understandable and about what data they have, how it's going to get used, and give them a real choice, right? Not just like sign this thing or you don't get your prescription, but to actually give them something where they can have some agency over it. And I think we're trying to do this in many of our projects. I mean, obviously, when we're subject to a law like HIPAA, we obviously follow the law. But with projects that don't have formal legal protection, so for example, the sensors that we're putting in the road system, we're trying to be transparent and simply talk to people about what we're doing, what we're not doing, and why we're doing it, so that they can feel a sense of trust that we are being careful and thoughtful with their data and they can make good choices around it. If you go to the intersection of Beacon and Mass Ave, you will notice a whole lot of things up on poles, which can be scary for people. You will also see at pedestrian eye level signs on the poles that say, the City of Boston is using data to improve traffic safety. For more information, and there's a URL there. And if you go to that URL, you will see in plain English exactly what this project is for, why we're doing it, what those cameras are collecting, how we're storing that data, how we're protecting that data. We are very clear what we're not doing, like facial recognition and license plate reading. And so the goal there is to say, we want people to be able to think about this at a human scale and walk away from that hopefully saying, like, I actually am excited to see this. I'm excited that these cameras are here because I understand why they're delivering a positive social value. I think if we can learn that lexicon, and instead of it being driven by lawyers who are protecting everyone's butt, like how do we actually talk to people in a way that they, as humans, say, wow, I want to donate my health data to this project because either I know it's going to improve my healthcare, or I know it's just going to contribute to the public good, and that's important to me.
I'd also add, I think I'm going to say something, and I've been in healthcare only 3 years. I'm a computer scientist, but I'm going to push back on this community a little bit. I have observed that when we do public health research, as investigators, we want the raw data. No one trusts, a summarization. I need to see the row level values. I need to be confident that the fields are not out of whack. There's not bad data or corrupted data. It's my name on that paper. I want to have real certainty that my assertions are correct. But that comes at a price. It comes at a price of securing that data, making it accessible, trying to manage the opt-in of that. I challenge our community to think about, are we ready to create almost like a trust network where I can query and understand the dynamics of that population of 10,000 individuals and understand the characteristics of it, the counts of it, without having to actually touch and hold and see the row-level details. I think that would accelerate the kind of insights that can be driven from this data and reduce the burden and cost and the risk and the lack of control that would be required if all of a sudden we have to push this data to every endpoint.
So I work for General Electric, and we're very focused on the industrial spaces, right? Healthcare, aviation, big commercial entities. And there's been this mantra that I've heard inside of my large company, which is that the consumer internet is very different than we'll call the industrial internet, right? And to which I joke and say, well, consumers essentially have no control over their data, yet companies and governments and universities, they got a lot of lawyers to protect all their data. Their data is much more hard to get to in many ways than consumer data today. And if you think about it, Jascha and I both have done open data portals for respective cities. The city of Boston is one of the leading cities in the world publishing its service data up to the internet. And you can just go to the data portal and you can pull down data that touches almost every aspect of city life. And the same thing in Los Angeles and New York and San Francisco and a bunch of leading cities. And so we have the sort of hierarchy, which is that individuals, I think it's probably safe to say that all of us, even the attorneys in the room, have given up data far beyond what our data has been given up and been distributed far beyond what we may even know about, right? Governments, by definition, because they're public, they actually have to publish their data to a certain degree, and there's an open data movement around it. So they're semi-transparent, if you will. And then companies tend to be very opaque, right? We don't, I think it's fair to say that commercial entities don't publish data unless they're required to under regulation. So now we get into the public health universe, and you get to the sort of funny space, which is that, if you're here in the city of Boston, Jascha has the ability to look at EMS data and say, how do we improve the service? And by the way, publish not only the data, but the results of that data to go and drive it for the public good. But if you're in a part of the country, for example, that is entirely private, they may not be publishing anywhere near the same level of data. And I'd love to figure out, discuss how we get more uniformity, maybe not necessarily requiring everybody to publish everything that they do, but be able to ensure that, if you will, all communities have the same level of service improvement that you guys are able to do here in Boston, and you're able to do within your network of doctors and insurance. How do we solve this? Is it forcing everybody to be interoperable?
I think forcing everyone to be interoperable is aspirational,
Yeah.
but tactically, I think it is starting very small and very simply picking a problem space and defining that domain and deciding what's important in the data set that needs to be shared. There's a multitude of protocols, microformats, things like that we could all adopt to make that sharing more accessible. But I think it needs to be centered around solving something, because if you try to be too generalized, I think that could be very challenging to accomplish something.
So in Boston and Los Angeles, a number of cities, there's a program which you know well called Vision Zero. How many people here are familiar with Vision Zero? Okay, so Vision Zero, let me use an analogy. So there are airplanes landing over at Logan Airport right now. And we all know that aviation is essentially the safest form of transportation, right? Very few people have wings, yet somehow or another we go through the air at 600 miles an hour safely. And there's a whole integrated system from soup to nuts that is there to ensure that aviation is safe. Yet by comparison, at the street level, automobiles compete with handguns and opioid addiction and things like that to injure and kill people. What's the number that we're going to get?
40,000 this year of deaths on American roadways.
It's up, what, 20%?
It's been creeping up for the last few years, I think,
Yeah.
from the mid-30s annually.
The newspapers in Los Angeles yesterday and the day before are filled with the fact that the traffic fatalities and serious injuries have gone up recently. And the head of transportation in LA, Salita Reynolds, is saying because we're actually driving more. And Vision Zero says, well, why can't we do for ground transportation what we've done for people flying through the air, which is to create a system which does not injure and does not kill people. Simple as that. Now, the funny thing about that whole goal, because remember, these collisions are one of the biggest causes of people needing to go to the emergency room across the street. I think we're all very familiar with what can happen. 4,000 pounds of metal versus 200 pounds of bicyclist or pedestrian, I mean, the results are very plain, right? And yet, when we get into, now let's talk about the data side. In California, when you call 911 in Los Angeles, you are connected to the LAPD CAD, the Computer Assisted Dispatch. And the operator, there are two of them, one in Van Nuys, one in downtown LA. The operator says, what are you calling about? 911, what are you calling about? And then the person says, well, there's been a traffic collision, right? There's an accident, I need an ambulance, I need paramedics. And so then they'll flip you over to the fire CAD, and the fire CAD then says, okay, we'll dispatch, a rescue ambulance to go to the collision. And data is collected right then and there. The police department reports that data up the chain, and it goes actually up to the state of California. And then 3 years later, it comes back down to the local departments of transportation, everybody else. It's called SWITers. And it's been deduplicated, it's been cleaned up. By the way, usually, of course, it's, messy data in, messier data out, et cetera. And then that data is used to go in and do analysis for Vision Zero. Meanwhile, the patient, who's been in that car collision is delivered to the emergency room. And it's a completely different set of silos of data. The emergency rooms are not doing surveillance to go and report the same data to the same agencies. And so it's very difficult for cities and agencies to actually do Vision Zero work because the data is so disparate, if you will. And then, of course, looking at outcomes and things like that. It's a very messy, difficult thing. And we're in the very earliest stages. So taking that as an example, and it has a direct effect upon public health, right? Decrease serious injuries and fatalities, improve the benefits of public health, right? How do you guys look at dealing with things like that? And I don't know the situation here in Boston, but I imagine that Boston has got to be at least as complicated as other places. So,
I mean, on issues of traffic safety, we do have a lot of collaboration between the different agencies and other organizations that are responsible for that to try to share data in a more real-time way, take rapid action, identify if there's an injury or a fatality. How does that knowledge flow to people who could perhaps go and make do an investigation and make a short-term intervention? But I think what you're getting at is actually a really interesting set of siloing problems that exists and is manifests in so many different ways in public health. So, take for example the challenges around supporting people who are dealing with homelessness.
Sure.
Somebody may show up at a shelter one day. They may stay for 2 nights. They leave that shelter. They generated data there. They may show up at another shelter on a different day. They generate data there. Those 2 records are likely not linked. They may show up in an emergency room or a treatment program. Those, again, data is generated, those records are not linked. So none of those social service providers is in a position to be able to make a smarter, informed recommendation for care or service delivery. They're not able to understand the history of what other services have been provided, what other challenges this person is dealing with in their life. And you just see this kind of problem repeated over and over again across the system. You can look at schools and the challenges that students face when they are dealing with housing instability. And that's not visible to the schools, but it may be visible somewhere else in the system. These are like really, really, really hard problems because it essentially involves not only technology, but it involves sort of a whole system of organizational silos, of financial incentives that all exist around a sort of single service model of delivering care as opposed to an outcome model of how we provide these social services. So the honest truth is, here in Boston, we're still learning how to do this. I think it starts with a recognition that in the health space, as our Public Health Commission has embraced the idea that social determinants of health matter, right? And we see a similar kind of approach in education to sort of say, not only education just isn't about teachers and classrooms, it's about, the social and economic and environmental factors that actually have an impact on outcomes for students. And so at least by recognizing where these silos exist and starting to understand the way in which things cross, we create the problem statement that we can then start to assemble data around and find specific interventions to take. I think there's some interesting work happening at the state level with this on opioids, of actually assembling multiple data sets because the urgency is so strong there that it's allowed people to actually get past a lot of their default, like, oh, no, that's not in my lane, and start to collaborate a little bit more. But we have work to do.
Yeah, we've actually, you may think as a larger enterprise, we can sort of mandate or dictate and sort our data much better than a public entity. But the reality is, very specifically, Optum is the creation, or it consists of almost over 70 acquisitions over the last 9 years. And each one of those at times can create that siloing.
Right.
We have tried to create things like unique identifiers, universal identifiers for entities like physicians or patients or members. And I would have to be honest, say that that's not been completely successful. Right. What we are exploring right now is recognizing that silos will always exist and will evolve, but what sort of analytics can we apply to help infer where there are relationships? And there are a couple of competing frameworks. Sometimes you might hear it as cognitive computing and others. What we've been using is a class of analytics called graph analytics to sort of understand the relationship with data sets and then apply really some conventional machine learning techniques to recognize when we might find, duplication or similar or overlapping records of information.
Right.
I think that's the most promising way to go, because I think if you try to converge the silos, I don't know why it didn't work, but it's just there's so much orchestration required.
Well, I think that it sort of comes down to what you're both saying and what I would intuit, and I think everybody would agree, is that these are not technology issues, right? We're actually now developing a set of technologies, graph network analysis, if you will, that really say, how do we deal with the human issues? Because the human silos are actually the things that are keeping us. And there's a related issue, which is that we all know, I think, where the future is, right? Which is, we know that at the end of the day, we should be able to go and say, change this behavior or promote this type of vehicle or whatever it happens to be will lead to reduced injuries and collisions and fatalities, if you will, in vehicles, or lead to reduced homelessness. A subject very close to my heart in LA right now. And all the rest of it, these human issues, and then the rate of change under which we can actually adopt these new tools, both organizationally and individually, is also another limiting factor. I would actually, we only have a couple moments left, but I just want to ask you guys one quick question. So you guys are both leading practitioners, right, in your space. You're driving change in your organizations. How hard is that? I knew that. You can use words, by the way, if you want to.
I'm not sure I could use some of the words that might come to mind.
We have challenges every day as an innovation center to drive change in this 200,000 employee organization. One thing that we've adopted from the startup community is derivatives around the lean startup and the lean stack, where we tried to have very constrained and very specific tests of our hypotheses, and back that up by actually, and we even have templates and documentation to experiment against them, and that even if the smallest piece of evidence can go a long way in aligning points of view. It may not answer everyone's questions, but it's almost going back to school in the scientific method. If we prove out incrementally and adaptively and agilely what the benefits might be, that seems to be a way for us to move this very large group in the direction that we wanted to go.
Well, and I'm going to step in front of you and talk about you for a second, which is that Jascha is always pushing, if you will, start with what you're trying to do and make it very, very tangible, if you will. I think we have time for one question. And so, ma'am, and microphone. Perfect.
Hi. My name is Portia Singh. I'm with Philips Research North America. I know it's been a popular topic in the past about having a person have their own health record and then walk it around, as you would say, to different areas. There's a lot of difficulty with that, but what prevents implementing something like that on like a city level? Most people will have healthcare in a specific area unless something bad happens, and they're outside that area. So what would prevent that from being implemented on a city level?
Shall I take a quick stab, and you want to? Sure. Okay. So, one of the challenges that you have is, quite frankly, the question was the following, just for everybody here, which is that there's been a lot of work done over many years, Google Health, HealthVault, and Microsoft, et cetera, to Apple Health Kit, people to essentially have their own health record that they walk around with and make available, to the health providers, the health service providers, the care providers, on demand. Is that a fair way of putting it? And what's keeping us from doing that at the city level? And to a certain degree, there's a really, I'm going to give you a very human reaction to it. And I'll do it from the point of view of California, because that's over there, so I won't out anybody here. But the fact of the matter is that when I stepped into the city government, I was kind of shocked to find out that the city government of Los Angeles had 38 different departments. And then on top of it is a county which has another, 80 or so departments, including all the health-related ones. So while the city would be providing, EMS and help against homelessness and everything else, a lot of that work was actually to interoperate with other governments who are then in the region, right? You have transportation agencies and public transit and, public health and all the rest of it. And then on top of that, then there's the state and the federals, and then there's the whole private and private universe, if you will. And nobody is well positioned to be able to actually say to their constituents that, in fact, here's a solution that you can go and have interoperate with everybody. It's really that human level. The technology, no big deal. I hate to put it that way as a technologist. People will throw things at me for that. But the human side of getting everybody to agree, I mean, just look at payments, right? How many different forms of payments do we need to get through the day, just to pay for everything from parking to the tea to, a taxi, if you will. You want to take a stab?
No, I think the only thing I'd add is, and I come from a primarily payer organization, but under our Optum Care brand, we are providing care to millions of Americans today as well.
Yeah.
We think that is possible. We are looking at new technologies like the underpinnings of Bitcoin. It's a technology called blockchain that give the data itself inherent policy and control back to the individual. We're still really early, but even the Bitcoin framework is relatively limited compared to like Ethereum and some of the new ones. But we think there's great promise there. A lot of people think the blockchain is going to change a lot of the way we have any sort of counterparty interaction. So we're hopeful that would be a way to create the kind of interoperability you're describing.
The technologies exist. Where we have is we have to get human beings to agree to now accept and work with these. So with that, I'm getting a hint.
It's a subtle hint.
Thank you for
the music is about to start. Please join me in saying thank you to the panel. We're just going to take a 5-minute break just to change the chairs on the stage, and in 5 minutes we'll start with the next panel.